Yeah. Okay. So thank you for joining us today for our trauma-informed care seminar. Our last but not least topic is about trauma-informed care in the primary care setting. And today we have Dr. Ross with us, who's going to be talking about this. And Dr. Ross is a psychiatrist and runs a hospital program, trauma program in the Dallas area. He is a past president of the International Society for the Study of Trauma and Dissociation and is the author of over 250 papers and 35 books. His books cover a range of topics, including trauma and dissociation. Dr. Ross has published a series of treatment outcome studies in peer-reviewed journals, which provide evidence for effectiveness of trauma model therapy. Dr. Ross has published papers and books on cancer and human energy fields, as well as literary works, including essays, fiction, poetry, and screenplays. He has different hobbies, including travel. So thank you, Dr. Ross, and we look forward to hearing your information.
Okay. Let me see if I can screen share successfully here. There we are. Perfect. So thank you for the number one, the invite, number two, the introduction. And I'm thinking that stopping at 10:30 is a little late, so I might stop a little before that. How about 5? So it's true, I'm a psychiatrist. I grew up in Canada, went to medical school there, did my psychiatry training there, worked as a psychiatrist for a while. And then I moved to the Dallas area in 1991. I was at Charter Hospital and then Timberlawn Hospital. Now I'm at UBH Hospital in Denton, which is a suburb of Dallas. And I'm just opening within a few weeks a partial hospital program in the Austin area. So I've been doing this for a little while. And when I was in my training, which was psychiatry 81 to 85, not a word about trauma. I mean, literally, no, nothing, zero. And so I had to go to my comprehensive textbook, which is this thick. It's 3 volumes. I still have it. The 1980 edition that told me everything I needed to know about psychiatry, which included way at the back of volume 2, a section called Topics of Special Interest, which really means irrelevant stuff we just put in for completeness sake, but you don't have to bother with it. But it's in there in case you want to read that. And in that section was a short chapter called Incest, which had one paragraph. So this is out of 3,300 pages, one paragraph talking about how common incest is, with a reference to a 1955 study saying it's one family out of a million. It's actually more than 1 out of 100. So trauma just did not exist, wasn't talked about at all. And so that was my training. And then when I went on the inpatient units as a medical student, as a resident, and I asked some questions like, what was it like when you're growing up? It's just this tsunami of trauma, massive amounts of childhood trauma, physical abuse, sexual abuse, verbal, emotional abuse, emotional and physical neglect. Um, and then that's just what's going on inside the family, loss of caretakers from death, divorce, imprisonment. So big trauma in all kinds of different combinations. That was a pretty common background story. And then we get the bullying in the playground, the sexual assault by the coach in high school, the sexual assault at the frat house, on and on and on it goes. The first abusive husband, the second abusive husband. So just from asking straightforward questions, it became apparent that trauma is this massive theme in the mental health field, which I'll show you some slides that it also is a massive theme all across the board in medicine, family practice, general practice, pediatrics, in prison systems, homeless shelters, everywhere where there's disturbed people, there's going to be lots of trauma. And so gradually over the years, which was a very uphill battle, basically from the women's movement became an increased awareness of childhood sexual abuse. And then tagged along with that physical abuse, and then adult onset sexual harassment, misconduct, et cetera, et cetera. And basically academic psychiatrists bucked that and fought that every step of the way. Flash forward to 2021, nobody can say trauma is rare. Everybody says, oh yeah, trauma is all over the place. But the working model of what psychiatrists in particular, social workers, psychologists, LPCs, what they do is really not very trauma informed today. And from my perspective, basically the whole mental health field, all social service agencies, prisons, on and on and on, all need to be trauma informed. So now I'm going to walk through what is trauma informed care with a focus on the primary care setting, but it's, as you'll see, very broad and general for organizations of all kinds. So what is it? What does it consist of? Why might it be useful? So just because I'm talking about prisons, or just because I'm talking about family practice, or just because I'm talking about high schools or businesses, it's the same general principles no matter which particular setting I'm talking about. And when you read some of the trauma-informed literature, it can be a little bit kind of pie in the sky, theoretical, in a perfect world, here's what we would do. But it also can be boiled down to very practical and doable. That'll be my focus. This is my contact information, should you want to email me if you have any questions or anything. So learning objectives. First of all, just what is trauma-informed care? A little bit on put it into practice with procedures and policies, and a little bit on the various challenges and the things that are going to get in your way. Might as well talk for a second about what do you mean when you say trauma? So I defined it a little bit. And like everything in the mental health field, it's a little fuzzy. It's not like, here's the x-ray, here's the broken leg. And part of the problem is, what's the difference between trauma and stress? Which is a whole big complicated thing. But when you boil it down, basically, I would say that trauma is extreme stress and stress is mild trauma. So we're all under, and there's a field in psychotherapy called EMDR, eye movement desensitization and reprocessing. It's a specific therapy model. They talk about little t trauma and big T trauma. So big T trauma is like fatal motor vehicle accident you survived, combat, rape, child sexual abuse, obvious big trauma. Little t trauma is just, it's a little more than the average day in and day out stress of life. But the point is, when you have a whole lot of small t traumas added up for a long time, that can put a lot of wear and tear on the system and in itself sort of evolve into a big T trauma, even though there's no single big T event. So news to everybody, the last year's been a little bit traumatic and stressful because of COVID. So we could debate, are we officially going to call that trauma? Everybody would agree it's stress, and quite a lot of stress, and all the school closures and everything, businesses failing, people declaring bankruptcy, not being able to go anywhere, do anything like you usually do, having to wear face masks everywhere. It's pretty darn stressful, especially for children and adolescents who missed out on a lot of socialization and absolutely did not learn as much from virtual school as they would from in-person school, and then missed out on all the socialization. And then just all the stress on the family of all the home childcare and homeschooling, basically. I say that as a veteran of the first day, being the caretaker on the first day of kindergarten, which was entirely virtual. That was a disaster. Kids all over the place, nobody focusing, nobody can get online. The instructions for how to log in are not right. So that's stress. So trauma-informed care, this is the National Association of State Mental Health Program Directors. And these definitions have been around for quite a while now, but they're not really implemented in for real in action. So it's care that's grounded in and directed by a thorough understanding of the neurological, biological, psychological, and social effects of trauma and violence on humans, and is informed by knowledge of the prevalence of these experiences. So the prevalence of childhood sexual abuse and incest is not one family out of a million. So a lot of seems to be common sense now, but it was a painful learning process for psychiatry and for the mental health field in general. So big point is we don't have all of the outcome data we would like. So we have to be evidence-based as much as possible, but we also have to rely on sort of expert opinion on what are best practices, what seems to be working, even if we don't have 25 randomized controlled trials. And it involves prevention, intervention, treatment services that address traumatic stress, and any co-occurring disorders that developed during or after trauma. These are all professional definitions. So basically, okay, how many psychiatrists are doing prevention of childhood trauma? Most of them aren't, because they're not child psychiatrists. Ones who are busy in their offices and at clinics and hospitals. The number of psychiatrists who are actually out in the world actually doing something specific that is preventing childhood traumas, like either zero or tiny. So again, some of these things are kind of pie in the sky, but it's basically built into the system in a structured, organized way. The effects of trauma, which include PTSD, depression, alcohol, all kinds of different things. And another point, trauma-informed care doesn't necessarily have to involve individual therapists who are trained in trauma therapy doing individual therapy sessions. It's also very much a system. So it's not like all of a sudden every family doctor has to hire 5 therapists, which is not going to happen. It's about the culture, which I'll spend more time on. So it includes both sort of general, broad definition, broad brushstroke trauma-informed care, but it can include, such as I have in my trauma program at the hospital in Denton, very specific, thought out, trauma-informed therapy, individual and group. So what are the guiding principles of trauma-informed care? So this is R and R. So trauma-informed care at the organization, program, or system level realizes the prevalence of trauma, recognizes how trauma affects all individuals, including those involved with the program, organization, or system, including its own workforce. So now we're talking in burnout, trauma in the workplace, impossible workloads, performance pressure, which from my experience is endemic in hospital organizations. Responds by putting this knowledge into practice, procedures, and policies. So you actually do something. You got to walk the walk, at least at the system level, and seeks to actively resist re-traumatization. So there's actually care and thought put into what are we going to do to take care of the people, the employees in the system, let alone the service providers, not just the people who are getting services. And I can tell you that in hospital systems, it's kind of close to zero on that. So it realizes the prevalence of trauma. Now I'm going to talk about the ACE study, which is very famous, the Adverse Childhood Experiences Study. And it was done in the 90s, but there's a whole series of papers ongoing. And then there's the Adverse Childhood Experiences Questionnaire, which is 10 questions about all these forms of childhood maltreatment, abuse, neglect. You get either 0 or 1 for each question, so you can score either 0 to 10. And it's very straightforward, easy to administer questionnaire. So for a system to be trauma-informed, just giving the ACE questionnaire is a very simple, financially viable, feasible thing to be doing. Except the problem then is you're going to find out about all this trauma and what are you going to do about it? So in this study, it's all Kaiser Permanente. Excuse me a second. This is the trauma of having grandkids intrude on your webinar. So Kaiser Permanente, it was in Southern California, and they enrolled 17,000 people. because they had all these massive files on everybody. And they asked all these questions from the ACE questionnaire and a bunch of demographics and so on. So gigantic data set. And these are the questions, and this is the prevalence. And this is out of the 17,000 something people, this is the women. And so, as you can see, physical abuse and sexual abuse are a quarter of the people. All these other forms of mother who was treated violently, so that's domestic violence, serious substance abuse, serious mental illness, separation, divorce, emotional neglect. So you can see some of these things aren't not too common, like a household member being incarcerated is only 5%, but 5% of 17,000 people, 5% of 330 million people, the United States has a higher incarceration rate than any other country in the world. And that produces tons of stress and trauma on the family just by itself, not even counting all the quotes dysfunction that led up to the person going to jail. So lots and lots and lots of all different kinds of abuse, trauma, neglect, dysfunction. And here we have number of people who score 0, 1, 2, 3, or 4 or more on the ACE scale. And as you can see, women and men, kind of ballpark pretty similar, basically. 4 or more, no, that's a little higher in women than men, but it's not like it's all women and no men. So lots of trauma for both genders. And 1 in 6 people have 4 or more of these types of childhood trauma. And when you score 4 or higher, your risk for numerous bad outcomes goes up dramatically. For instance, the odds of you doing IV drug use, recreational, goes up 1,400% if you score 4 or more compared to 0. So enormous increases in risk. 4, welcome to family practice, internal medicine, pediatrics. All these different things go up in a very dose response curve kind of way. Alcohol abuse, chronic lung disease, which you'll see over here is smoking. So obviously, the more you smoke, the more lung disease you have, the more trauma you have, the more you smoke, the more trauma, the poorer the self-care, the more trauma, the more depression, higher levels of fetal death, health-related quality of life goes down, illicit drug use up, ischemic heart disease, liver disease. So again, liver disease, that's obviously going to have a bunch to do with drugs and alcohol, unprotected sex, etc. Heart disease is going to have to do with lousy lifestyle, lousy nutrition, cholesterol, blood pressure, blood glucose, weight, all up. But your work performance goes down, your financial stress therefore goes up, your risk for intimate partner violence goes up because you don't have the best self-esteem. You think that that's all you're worth is being a punching bag or a sex object, and you don't have good boundaries. And so when you're abused as a kid, your odds of being abused by your partner go up. Multiple sexual partners way the heck up. So I was kind of, I grew up in Winnipeg, Manitoba, which is dead center. It's almost due north of Dallas, Austin. And it was about 350,000 people when I moved there in the 50s with my family, and it was 650,000 by the time I left there in 1991. And I moved around to several places in the interim. But I remember reading in the Canadian Medical Association journal very, very, very early in the AIDS epidemic, a survey in Vancouver of gay men and how many sexual partners had they had, and a whole list of health problems, including HIV. And they divided the categories into, so you might think, 0 to 5, 5 to 10, more than 10 sexual partners. The categories were 0 to 100, 100 to 500, and more than 500 sexual partners. So obviously your risk of sexually transmitted diseases goes up, and then all kinds of HIV, bad health outcomes, for gay males, all kinds of anal sphincter problems, on and on and on and on and on. And the risk for all of that goes up with ACE score. Suicide attempts, unintended pregnancies, early initiation of smoking. So it's not just your risk of smoking, period. It's how early you start smoking. Same with sexual activity, therefore adolescent pregnancy, risk for sexual violence outside the family, outside intimate relationships, poor academic performance, which leads to poor work performance, which leads to financial stress. So it's a whole set of feedback loops. But it's a lot of what occupies family practice, internal medicine, pediatrics, and then we'll spill over into pulmonology or cardiac bypass procedures, liver transplants, just goes on and on and on and on. So it's not like I do physical medicine and we send our people over to mental health system. All this mental health and physical stuff and trauma are all in one great big ball. And even if you don't realize it, it's going one after another through your practice, your facility all the time. So getting into what is trauma-informed care then. So it's got these, basic core things. So again, we're really just talking common sense and common human decency. Like, how should professionals behave in the workplace? Well, they ought to behave a little different from how they often do. So just go through these quickly. Safety. So welcoming intake procedures. So this doesn't mean you have to sit in the intake office for 6 hours before they get to you because they're so understaffed, overstressed, burned out, and they're not like overtly rude to you, curt, busy, looking at their computer and barely looking at you. That's not a welcoming intake procedure, but it's common. So it's from the second the person walks in the door. So that means in a primary care setting, that means first of all, the place is physically welcoming and halfway homey. The receptionist is pleasant. The nurse who walks you back, it's every step of the way. Cultural safety. So this doesn't mean like different cultures around the world. This is the culture of the workplace. That consciously it's talked about, it's in manuals, it's in policies, it's in all this printed stuff, it's in trainings, it's talked about at staff meetings, and a neutral, objective, and supportive language, which is a big deal these days. So in our trauma program, which is at the hospital in Denton, everybody's got a trauma history because it's a trauma program. Back in the 90s, it was a pretty unusual thing to have a transgender person in the program. Maybe like 1 or 2 a year, and they like really stood out. And then 2000 to 2010 sort of kind of crept up a bit. But in the last 10 years, we have trans people like regularly. So if there's 15 people in the program, the odds are high there's going to be at least 1, if not 2 or 3 trans people. And that's both male to female, female to male. So therefore, we've had to kind of get up to speed, no thanks to organized psychiatry to my textbooks, with all this vocabulary. Are you cisgender or transgender? Are you straight or gay? Are you this? Are you that? And then it's gender neutral or asexual or pansexual. So there's all this vocabulary, which is a little overwhelming, but you need to be at least a little aware of it. And you have to make an effort to just use the vocabulary that the person asks you to. And if this is my experience, if you like goof up and say he instead of she, but you're like behaving decently, treating them decently, you're obviously not transphobic, you're talking about it, you're working on it, you acknowledge it, people are usually very forgiving. They realize that it's hard to remember to say they when you're talking about an individual person. So it's important. And then we get into, what's the correct term for this racial group, that racial group, that racial group. You just have to be kind of up with the times and sensitive about all these things, which is not easy in a busy work day with, I don't know how a family physician does 40, 50 patients a day. It's inconceivable to me. And so again, that's got to be in the words that come out of your mouth, the words that you're thinking, and to some degree discussed at team meetings, maybe some policies and procedures about it. And people often, when they come to the trauma program, it's basically an acute suicide program, because that's what has to be in place to get approved by managed care to be an inpatient. And people all the time say, what are you here for? What is it you want? I just want to feel safe. Paradoxical thing is, a lot of the times the biggest threat currently is from themselves, because they're the ones who are cutting on themselves, threatening to kill themselves. But people with trauma histories absolutely do not feel safe. And the more you can make them feel safe in the environment, the better. The less difficulties you're going to have, the less conflict, the less crises, the better the treatment alliance, the better the complying with the treatment recommendations. Which again is all just boils down to being decent and sensitive and listening. So being reliable and predictable with clear boundaries. So you have to be trustworthy and be open and honest about your skills, knowledge, and limitations. Which is, again, easy. Like, okay, I'm not a brain surgeon. We're going to have to refer you for an MRI, and then maybe a neurologist, probably a neurosurgeon. It's outside my scope of practice, but we'll be here to participate in follow-up. Just straightforward stuff, but being predictable with clear boundaries. So in the inpatient setting, everybody's had this massive childhood trauma, dysfunctional, like letters this big, massive dysfunctional families. And we want to be the healthy family, the treatment family. So we have clear rules, clear boundaries. And it doesn't mean that you coddle people or they can get away with anything they want, or there's separate rules because they've had trauma histories. People need to learn that in the real world, everybody's not going to coddle you and feel sorry for you. You got to learn to regulate yourself. And when you're here, here's our rules and our boundaries, which could lead all the way to we're discharging you from care here. You're too disruptive. You act out. You cause too much trouble. You're doing all these things that are way, way, way beyond the limits. So it's not a soft love. It's more like tough love, but it's not delivered in an in-your-face kind of fashion. And just basic, clear information about what is the deal here? What hours are we open? Who's going to see you first? What are the different roles? So you think that's all obvious. You think that you already do that. But I remember when I was in medical school, this guy who was early in the history of Hodgkin's lymphoma can be treated successfully. And he had Hodgkin's lymphoma, really good response. Some years later, he comes to lecture the medical school class. Here's my personal experience as a cancer survivor, being a patient, being in hospitals, being on chemo, etc. And horrible stories about, for instance, how was he given his diagnosis of cancer? The doctor gave him the diagnosis standing outside the elevator. He was inside the elevator as the elevator doors were closing. So that doesn't quite qualify as trauma-informed care. Choice, so maximizing choice and control. And so in psychiatry, that turns into basically a consultant, colleague, sounding board, discussion approach, as opposed to, here's your prescription, take this, see you in 6 weeks. It's got to be, okay, here's your options. It's up to you. I probably recommend this one, but there's several good choices here. And that would be the same in no matter what kind of service you're providing and what the discussion point is, and no matter what the options are. Kind of touched on this just a second ago. Clear and appropriate message about rights and responsibilities. So you have the right to the following, but you also have the responsibility to do the following. We have a few rights. We have the right to not be shot and not be punched and not have a car driven into the front of the office, et cetera, et cetera. And we have responsibilities. So clear definitions, clear roles. And I touched on that. Ask what pronoun people prefer. And sometimes it doesn't exactly make sense to me, but I'll go with it. So collaboration. So instead of I'm the doctor, you're the patient, I'm the expert, you're the consumer, I'm telling you what to do, you follow my doctor's orders, which is the bottom line, but it's all about how it's delivered. So instead of I'm bossing you around, which we know that 50% of prescriptions are not taken as prescribed all across the board in medicine. So anything you can do to ramp that up by being collaborative, by sharing power, by letting the person be the person who's in charge of their life and living their life, and the less you're bossing them around, the better. Because the person, I kind of don't like this expert by lived experience phrase. It's kind of overused, but the concept is good. And so I work with people with multiple personalities where they have all these different parts inside, and one part doesn't even know what year it is, doesn't even realize that they live inside the same body, and they're wanting to kill the out front person so they can take over or just to get rid of her. And they don't even know, like intellectually, that if they kill her, they'll be dead too. And so I'm commonly talking to those parts. It's called talking through. So you talk to the part who's listening in the background. They answer inside the person's head. The out front person tells you what they said. Or sometimes there's a switch and the part comes out to the front. But basically, I make the point over and over and over and over with these hostile, uncooperative, suicidal parts. I'm an expert on the outside. I've talked to lots of people and been to lots of conferences. So I'm the doctor expert, but I'm not the expert on you. You, the part inside who's all hostile and angry, you're actually the expert on what's going on in there. I barely even know you at all. So I'd like you to be a consultant to me rather than I tell you what to do. So all these principles of trauma-informed care become very specific and detailed in the therapy conversation. I want you to keep an eye on the therapy and tell me what's going on. And if you don't like something, or you think, no, we don't need to be talking about that right now, we need to focus on this, or she needs this, she doesn't need that, let me know, because I don't know. I'm not in there. I haven't been living inside there for all these years. So the more hostile and uncooperative the part of the person, the more I want to hire that part as a consultant to the therapy. And then that just disarms a lot of the hostility. And the person's like, wow, nobody ever wanted my opinion before, the part of the person. And she's just been trying to get rid of me, and nobody's ever listened to me for 5 seconds. And all of a sudden, you got a cooperative part. Same with people who don't have multiple personalities. And then I commonly say things like, so I like to joke around in therapy, and I don't talk real different in therapy from how I talk outside therapy. So I'm not like, oh, now I'm the psychiatrist, I have to talk this way. And I'll say to people, not uncommonly, somebody with massive trauma and all kinds of self-mutilation, drug and alcohol problems, dysfunctional relationships. It's amazing that you can even walk and speak in sentences with what you've been through. So that's a treatment for self-esteem on the one hand. It's just stating the facts, and it really is amazing. So I like working with really traumatized people because they're such amazing, strong, resilient survivors, full of self-defeat, self-hatred, hopelessness. But if you can get them to see their own resilience and their own survivorship and their own power, now that's something you can build on. And a lot of times you don't have to do 100 hours of psychotherapy. It's simple, brief comment, a sentence or two. So empowerment, and prioritize empowerment and skill building. Easy to say, not so easy to do, especially to a busy family practice. But again, it's just these simple things. Okay, you're in charge. I want you to know if this is working for you. I want you to tell me if it's working for you. If it's not working for you, what do we need to change? Does this make sense to you? Do you really, really want to follow this path of taking this medication, checking your blood levels, or your sugar levels, whatever it might be? And there's a buzzword in the mental health field now called mindfulness, as if like nobody ever thought of this before, that you should pay attention to what's going on internally, kind of track your feelings and your thoughts. But it's become sort of a general principle of therapy that's just more clear, more emphasized. So being mindful about power and control dynamics is very useful and important. It's pretty hard to form a working relationship with a hostile teenager by coming on as the power control adult. And so a lot of the times it's just being aware of it, being sensitive to it, and just, again, being a decent person and using common sense. It's not like you have to have this giant manual or start doing things completely differently. But the sad fact is that there's so many examples of professionals violating all these principles all the time. Validate, affirm, and emphasize growth. Again, you would think it would be obvious, but how often does it actually get done? So you're training an adolescent who has juvenile onset diabetes on how to monitor blood sugar, how to take insulin, and so on. And that's a tough assignment. And the more you can do all of these things, the more compliance you're going to get, and therefore the better long-term health outcome. Institutional re-traumatization. So sad to say, but all of this stuff goes on a lot in the mental health system. And there's research papers, well-designed research papers in like pretty high-ranking journals for any kind of diagnosis, but a couple of papers specifically people with schizophrenia. And surprise, surprise, 2/3 of people with schizophrenia meet the criteria for PTSD because literally their childhood has driven them crazy. So there's a huge relationship between your ACE score and your risk of psychosis, like big, statistically massive significance level of relationship. So psychosis is not just a brain disease that has nothing to do with trauma. That's completely mistaken. And in this one study, 2/3 of people with schizophrenia had PTSD. And of them, a third or half, their PTSD came from what happened when they were in the psych hospital. Just takedowns and being ejected and in seclusion, thrown in seclusion, all this kind of stuff. So the mental health system is literally creating PTSD in consumers who come there for treatment. And client blaming is just out of control, gigantic. And the way going back to my residency now, which is 81 to 85, fast forward all the way to the future, borderline personality disorder. That's a diagnosis that's been in the DSM 1980, DSM-3, 1994, DSM-4, 2013, DSM-5, it'll be in DSM-6. And there's a big literature on it. So there's 3 meanings of the word borderline, basically. One is the diagnostic criteria in the DSM. So it's just a behavioral symptom checklist. It's objective. There's statistics about it. The second meaning of the word borderline is a whole bunch of theories about what's going on in your defenses and your psychological structure internally. And the third meaning of borderline, which is used a lot in the ER, a lot in the mental health system, a lot in the psych unit, is borderline's this and borderline's that. Can you believe what this borderline did? So I was trained just by sort of programming and social conditioning, not by intellectual lectures, that if the diagnosis is borderline personality disorder, it's always a female, They're always yanking your chain, attention seeking, manipulating, trying to get this, trying to get that. You want to keep them out of the hospital. Because if they come into the hospital, they'll just regress and cause you a headache and have all these crises. And it was a massive chauvinistic, male chauvinistic, paternalistic, I'm the doctor, you're the sick patient. But you couldn't talk that way about people who were depressed or people who had schizophrenia. You had a license to talk that way about borderlines because borderlines this and borderlines that. So it was client blaming to the max. And at the inpatient level, never, ever, 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 ever do you meet somebody who has depression, suicidal ideation, borderline personality disorder, substance abuse, self-mutilation, who did not have tons of childhood trauma. Maybe out there in the community, there's more high functioning. Maybe those people meet criteria for borderline, but maybe it's some sort of variation on bipolar disorder. But when you have suicidal, inpatient, borderline, depressed, you have tons of PTSD, not to mention dissociative disorders that I specialize in, those people get blamed for what is very understandable consequence of the trauma they've been through, which I lecture on. That would be a whole like hour and a half just to go into that. But that's the maximum example of client blaming, and it can be like vicious. So emphasis on compliance, we kind of touched on that, misuse, overuse of power, and ignoring the emotional needs of the patient. So I remember, I had a hand injury from a forklift when I was working in the Canadian Arctic, and I had a couple of surgical procedures. And so I'm in the hospital for basically plastic surgery revision. And my left hand was kind of bandaged up. And I was in the hospital for a few days and like my hair is getting kind of itchy. And so I was just asked, so the nurse was one of the nurses on the surgical unit. And none of this was life-threatening to me or anything. So I'm perfectly cooperative. I'm not causing any kind of trouble. And the nurse has 6 patients. So she's on an 8-hour shift. She's got 6 patients. You think she might be able to carve out half an hour face-to-face with each patient? No, of course, she's at the nursing station filling out paperwork. And I had to like not whine, plead, but negotiate with her for a couple of days. And I had to tell her to get her to shampoo my hair. And so I had to tell her, look, all you have to do, it's just going to take you 30 seconds, literally. I'll have it all set up. I'll wet my hair. The shampoo will be right there. I just need you to do that and swoosh it off. I'll be leaning over in the bathtub. I can dry it myself. That was 2 days of negotiation just to get that done. Jeez. That was my emotional need to have my hair washed. And just be aware of potential past organizational trauma. So when people have been mistreated, you think people get mistreated in jails a little bit, in the criminal justice system, homeless shelters. I've had lots of people describe to me that they won't go to a homeless shelter, especially women, because there's so much crime, assault, and trauma going on. But I've had many, like hundreds and hundreds of people talk about how badly they've been treated in the mental health system before. And so you expect those people to walk in and just say, yes, doctor, I trust you and I'm going to follow your orders. Not going to happen. And then we blame them because they're not cooperating, which is just more non-trauma informed care and more re-traumatization. This is sort of a little bit of a side point, but also a core point. So trauma-informed care is not about building a trigger-free world. So what is a trigger? So I always use the example. So about 90% of people who come to my trauma program are women. That's because they've actually got the guts to come, and the men are too scared to deal with their feelings. Men have got lots of trauma themselves, but they're out in the world perpetrating it on others. Whereas the women are more socialized to internalize it and perpetrate it on themselves, and they're more willing to talk about their feelings and work on recovery. So therefore, it's 90% women. So it's always huge amounts of childhood trauma. So let's say this woman was sexually abused by her uncle, who always had on a blue baseball cap. Now it's 30 years later, she's walking through the mall. A male who maybe doesn't even particularly look like her uncle walks by with the same blue baseball cap, completely triggered, has a flashback, overreacts, gets hysterical, and maybe even gets suicidal or gets agoraphobic and won't go out. So that's a trigger. A trigger is some small thing in the present world that's not that much of a threat, but it's a reminder of what happened in the past. So when I'm explaining this to the female, which can be cis or trans female, same story if it was male, I'll use the example of, okay, let me explain about PTSD to you. So there's this combat veteran. He's like a big linebacker sized guy, special forces, tough. And he's back from deployment for 10 years. He had multiple tours, tons of combat. And he's in the backyard and he's grilling his hamburgers and everything's good. A news helicopter flies overhead. All of a sudden, he's in a total flashback. He sees it, he feels it, he smells it. He's in combat. He doesn't even know what year it is, and he dives under the hedge. Everybody's got to like calm him down and reorient him. So what's with this guy? So we don't say what's with this guy. We say thank you for your service. We see it's PTSD. We understand this is not because the news helicopter is a threat. It's a reminder of the helicopter that was flying over the combat zone when his buddy got killed beside him. Thank you for your service. This is PTSD. You're tough, you're strong. But what if the gender is female? And what if the trauma was childhood sexual abuse, physical abuse, emotional abuse, and the person gets triggered? Then we say, borderline's this and borderline's that. We trash talk the person. So then you would think that, which actually happens, people come into the unit, which is just a microcosm of the whole world, and they get triggered by something and they want you to take the triggers away. So if we had some like horrendously pornographic painting on the wall and somebody got triggered, we wouldn't go smarten up. We would go, who's the idiot who put this up on the wall? But you can't just take away all the little triggers. Like if a salt shaker is a trigger for somebody, everybody else needs to have a salt shaker. So if you're overboard in the direction of, oh, poor you, we have to insulate you from all these triggers, you're just making them the helpless victim that needs to be managed from the outside. And they're not learning how to practice dealing with the triggers, which are everywhere in the world. So it's all, it's a lot of balance. It's not all coddling and feeling sorry for and making exceptions. It's a lot of learning, and it's over on the tough love side. So it recognizes, we're going through the R's here, how trauma affects all individuals, including those involved in a program, organization, or system, including its own workforce. And this is all stuff, again, that's obvious. We all know it. We recognize it. The VA knows it. The Department of Defense knows it. The official statistics are 20% of people coming back from deployment have full active PTSD. And according to the VA, the most common cause of PTSD in returning deployed female members of the military is rape by an American soldier or military member. That's according to the VA. So what we also know, I don't know what the exact number is currently, but it's like in the low 20s of military people killing themselves every day in the United States. Back in the 70s, I guess it would be, maybe early 80s, 50% of homeless people in the United States were Vietnam combat veterans. So I was in a facility in San Diego, a military facility, giving a workshop on trauma. And I was talking kind of like this, and I went through the 20% of women coming back from deployment who have PTSD. It's from rape. And there's probably 40-ish people in the talk, some medical people with lab stuff, some people in civilian clothes, a bunch of people in military uniforms. And there's three women sitting beside each other in their military uniforms, very erect, with tears flowing down their cheeks as I was talking about rape in the military. And so what do we get from the leadership? Rape is wrong, rape is bad. But it's going on all the time, all the time, all the time. So the organization itself is traumatizing its own members, and then it sends them out to get re-traumatized, and then they come back and they get some PTSD treatment, but a tiny fraction of what they need. So triggers, just a little into therapy here a bit. Triggers can be on a scale from 0 to 10. And if you're at 0 on the trigger scale, everything's fine. If you're at 10, you're in a total flashback relive. You don't even know where you are. But all of these things go 0, 1, 2, 3, 4, up all the way up to 10. So you can be triggered at the 1 or 2 level, and you're just feeling kind of nervous, kind of uncomfortable. You can't put your finger on it because you don't consciously track what the trigger is and why it's a trigger. So a lot of times it's just kind of out of proportion reactions, but that's not big theater, but it happens a lot. So then this becomes a criterion for borderline personality disorder, emotional instability, and then we trash talk the person for being a borderline when it's all unresolved trauma. So uncomfortable feelings and warning signs in the mind and the body. In therapy, we teach people to be mindful, to track this, be aware of it, what's going on, what's the trigger, what's the reaction, how does that connect to the past, some breathing, some grounding. And then it goes up from uncomfortable feelings to anxiety, fear, and then full-on flashbacks, despair, suicidal thoughts. So just because it's mild doesn't mean you're not on the trigger scale. So that just fits with trauma is everywhere, including in the waiting room in your practice. The parallel lives is a cool little model. So there's the here and now, and then there's the there and the then. So you're just going along in the here and the now. Past is not intruding. Then something happens, which is probably going to involve a trigger. Huge emotional reaction. So this is the combat vet with PTSD. And then it just explodes into the current moment, way out of proportion, out of context. So again, if you're a female, you're being hysterical. If you're a male combat veteran, you're having PTSD and you're a tough guy. And now, there and then is now. It's all just mishmashed together. People can actually be cognitively not aware of where they are at the extreme end. But usually, like in a private practice or group practice or outpatient office setting or urgent care center, even in the ER, you're going to be lower down on the trigger scale most of the time. What are the views of self and others that go along with all of this? They're the feelings that were the reality of the person's childhood. I was small, powerless, helpless, trapped, overwhelmed. I couldn't fix it. I couldn't escape it. So I felt powerless, helpless, out of control. And then, so physical trauma can, sticks and stones may break your bones, but words will never hurt you. Completely not true. You can have really severe emotional, psychological relationship with other people, spiritual relationship with God and the church, all kinds of damage at all kinds of levels, from verbal emotional abuse, emotional neglect. Then you add on physical and sexual abuse, it gets even worse. But the basic outcome is, just like physical trauma, you're literally damaged in your thinking, your feeling, your relationship style. And you feel unworthy because day in and day out, the message was, you're not worthy of unconditional love. You're not worthy of being protected. You're just either a doormat, a punching bag, or a sex object. And so how do you feel about other people? Well, you feel unsafe, and you think that other people are untrustworthy, and you fear authority figures because you grew up at the school of fearing authority figures who are very scary people. So all this trouble in a relationship with the doctor, the nurse, the whatever professional is completely understandable. It flows directly and automatically from how they were treated as children. So this is kind of repeating: tracking and regulating affect. That's the mindfulness. And dissociation basically means disconnection. So sometimes when you dissociate, you like trance out, you're gone. But you can be, yes, doctor. I've been experiencing considerable amount of pain. The motor vehicle accident was quite severe. I was the only survivor out of 3 people in the car. So, okay, so you're getting this robot report, but there's no emotion there. So that's the motion is disconnected or dissociated. So basically, the person's not all fluid, integrated, balanced. They've got disconnected little bits of feelings and bits of memories and bits of attitudes and bits of behavior. And they're getting triggered all the time and overreacting. So it's just, which obviously in gynecological exams, their odds of that happening is going to go way up. So just kind of keeping an eye out for it. And then simple grounding. So I always compare it to when you're on an Alzheimer's unit. What do you see on the Alzheimer's unit? Well, okay, there's the arrows on the floor. There's the sign. This is Sharon's room. Today is Tuesday. Okay, you're at such and such a facility. This is my name. You're safe. It's this year. Your daughter's going to come and visit you tonight. Just simple, basic, dementia reorienting skills. Funnily enough, are very useful for people who are triggered in half or 3/4 into a flashback. I remember somebody with serious trauma. Weren't sure exactly how accurate her story of her childhood was, but she clearly had lots of dissociative PTSD symptoms. And she was kind of semi-catatonic, dissociated, tranced out in the hallway. And the other psychiatrist, who was her psychiatrist, I happened to be walking down the hall, is saying to her, like, in a very gruff voice, "I need you to cooperate. You have to cooperate right now." Of course, she was just getting more traumatized, more out of it. And so I knew her a little bit. I just kind of eased in, took over, talked calmly, got her regrounded, and she was good to go. An extreme example of that, which you're not going to bump into every day, is when I was in Canada, I had somebody with multiple personalities in my private practice, which was not private practice. It was in the office in the university teaching hospital. But she was at another emergency department at another hospital. And the doctor knew that I was her psychiatrist. So she's in 4-point restraints on a gurney in the ER, completely wildly uncooperative. And he's in desperation. He's glad he gets hold of me on the phone. And he describes the situation. "Oh, I know who that is. That's so-and-so," because she wouldn't say her name. But he knew that. I can't remember how he knew that I was her psychiatrist, but he knew. And say, "Okay, well, just, of course, this is not a mobile phone. This is a huge, long phone cord. Put her on the phone. So, "Hi, this is Dr. Ross. Who am I talking to?" "Well, this is Joe." "And okay, so you're in the ER at such and such hospital right now. You're all tied down. You're not going to get out of there unless you calm down and let Susan come back. And I can talk to you in the next appointment in 3 days. So would you be willing to go back inside? Otherwise, you're just going to be stuck here tied down and they're going to start injecting you with drugs." And, "Oh, okay, sure. Okay, so Susan, can you come back? It's Dr. Ross." "Hi, where am I?" "Well, you're in the ER at such and such a hospital. So-and-so inside was causing some ruckus, but he agreed to go inside. And everything's good?" "Yeah, I'm good." "Okay, give the phone back to the ER doctor." "Okay, she's good to go." He was astounded. And otherwise, it's this nightmare psych case, and there was no psych beds available. He's going to be stuck with her. So the simplest intervention had massive payoff for everybody concerned.
Dr. Ross,
Yes.
I was just going to say we're right around 4:30 or so. I just want to remind the attendees to put any questions in the Q&A box, and
Okay.
also it's kind of for you to be aware of the time.
Yeah, I see. Is that 4:30 Central Time
Yes,
in Texas?
yes,
Okay, I got it.
not quite 10:30.
Okay. Well, I'm glad to hear that. So dissociation is a big theme. I'll just touch on it here. And there's dissociative disorders. And just like trauma is massively ignored in the mental health field, dissociative disorders, which are very connected to trauma, are also massively ignored and poo-pooed, and there's all these attitudes about them and so on. Uh, like I said, though, it just means disconnection from self, others, the world. It's a synonym for disconnection. And it's protective, and it's a survival resource, not only in all humans, but all mammals. So mammals, you threaten, corner a mammal, you're going to get some combination of fight, flight, or freeze. So fight, that's the anger, aggression. Flight is fear, panic, terror, escape. And freeze is freeze. So there's lots of videos on YouTube, and sometimes they come through Facebook and so on. Um, there's the cheetah chasing the whatever type of gazelle type animal it is. And this one particular video, it was actually a lion in that video. It's kind of like the gazelle's on the ground, the lion's on top with one arm and paw over, or leg. Technically, I guess lions don't have arms. And I mean, it's game over basically. And what's that gazelle doing? Completely immobile, can't even see it breathing, eyes are not blinking. So it's like, is that animal even alive? And then a troop of baboons or something comes by, or no, it was like little warthogs or something. I can't remember what type of animal. And they start like pestering the lion. And the lion kind of gets a little distracted and takes the leg off. And then the lion gets up and leaves, which is very good luck for the gazelle. And then you just see over a period of a couple of minutes, okay, now I can just see the chest wall starting to move a little bit. And then I feel like a little bit of blinking, and then a little bit more rapid breathing, and then lift the head up a little bit and look around, sort of disoriented and dazed, and then hyperventilating, scared. So we go from freeze into flight, and then all this wobbly trying to stand up and shake it off, and then the gazelle runs away. So that's freeze. And people commonly freeze, like in rape situations, muggings, all kind of combat. There's a very vivid one in Saving Private Ryan where one of the members of the platoon just freezes. So freeze, I work with lots and lots and lots of people who've been raped as adults, not to mention age 5, 10, 15, 20, whole time they're growing up. And not uncommonly, they go into a freeze response. And then they're beating themselves up because they didn't do anything. So I'll teach about fight, flight, freeze. I'll say, this guy was, how much he weigh, how tall was he? Did he have a weapon? Did you try to run away? What happened? If you tried to wrestle with them, you'd just lose, you'd get it even worse. There was nothing to do. Fight and flight were just not going to work. The only option left was freeze. And then I might tell the story of the gazelle. It's a very smart strategy. It's survival. It is doing something. Freeze is doing something. So lots of education, just kind of, again, it's a little bit of understanding biology, a little bit of technical knowledge, but a lot of it just common sense and decent attitude. And so this is extremely common in trauma survivors. They seem disconnected from themselves. They're not quite with it, but they're not having a giant flashback. And so that's like big D dissociation versus little d dissociation. So these little d dissociations of just kind of not being there, not being tuned in, not being attentive, sitting on the couch and like half an hour went by and what the heck happened? But it's not like another personality took over. Well, those are cumulatively, those small D dissociations can be very disruptive. And you can see it happening in the office. Um, so I know somebody in my personal life who's a dental hygienist who's very aware of their patients, not tiny number, who they just have so much trouble with anybody putting anything in their mouth, whether it's a mirror or whatever it might be, and the gag reflex going like crazy when you just like touch the front of their mouth and there's a gag reflex. And she doesn't ask them, she doesn't know for a fact, but since hanging around with this weirdo psychiatrist person, she's become aware that, yeah, I bet a lot of those people have been orally raped as kids. And then obviously gynecological exams, breast exams, anything can be a trigger. So grounding. So again, that's like the Alzheimer's unit. It's just simple stuff. Talking consistently in a calm voice. Okay, you're here. This is where you are. This is the office. This is my name. You're safe. Nothing's going to happen. And then there's do this with your fingers. Look around. So that's in World War II, it was called the 1,000-yard stare. You want to not be staring because that keeps the trance state in place. Look around. Okay, see, I'm looking around my office. There's the work of art. There's the book, or there's the floor. Shuffle your feet. Feel the arms of the chair. Touch your shirt. Simple, simple, simple grounding can really de-escalate the situation. And that can be the case when the person appears to be perfectly oriented, but they've been triggered and they're all having this emotional overreaction. Those grounding skills don't have to be for tranced out, cognitively not there. Okay, so understand how to put trauma-informed care into practice. So that's kind of what it is, but how do you put it into practice? And how to get it embedded in your procedures. So first of all, like anything, you can't solve a problem if you haven't identified the problem. So what is the problem that being trauma-informed solves? And what is the goal of trauma-informed care, and how can you evaluate it? So I have no idea, so I'll just skip that slide. Well, like anything, again, it starts with a needs assessment. So self-assessment of oneself as an individual, self-assessment by the organization, examining your current practices, and taking specific steps towards becoming trauma-informed. There's everything on the internet these days. There's books on everything. There's webinars on everything. There's websites that talk about it. You can Google everything. Same with trauma-informed care. So it's, again, you just have to set aside some time. We're going to have a trauma-informed team meeting or case review or discussion or update, or we could add something to our printed handbook or whatever it might be. So it's not just talking, it's walking the walk. And then it's actually, you decide what are these trauma-informed care principles and practices, and then you just got to put it into action. Very much little step, little step, little step. So in trauma recovery therapy, we talk about desensitization, which is you've got a trigger, whatever it might be. So say you live in the wrong part of Texas and there's snakes all over the place, and you're going to get behavioral desensitization from a psychologist. Well, you don't start by throwing the person in a snake pit. You got to start with, okay, we're going to practice some breathing and some grounding. You're focusing on your breathing, slow your breathing down, concentrate on your breathing, count how many seconds in, how many seconds out. That switches you out of sympathetic system dominance to parasympathetic, which de-escalates everything. So breathing is incredibly useful and helpful. It's simple. So, okay, here's somebody who's out of it, overreacting, traumatized, stressed out. We want to desensitize that person to the snakes, little step by little step. First of all, practice our grounding skills. Then we'll talk about the subject of snakes. Okay, you're getting a little ramped up. Breathe, focus, ground. Okay, now we can talk about snakes because there aren't any in the office and they can't get in under the door. Okay, now I'm pretty comfy just talking about snakes. Okay, now we're going to look at photographs of snakes. Oh my God. The same thing. Then we're going to have a rubber snake on the far side of the room. Okay, now you can sit in the room. It's just a rubber snake. It's not going to jump on you. Go and touch the snake. So you can break it down into all these little steps, and then you get to, okay, this is just a rubber snake. I'm not scared of this. Okay, now let's go to the pet store. And I worked with a person like this in Canada where it was monumental just to drive to the parking lot in front of the pet store. And this person was small, furry animals, which is a huge problem because her daughter had a dog. There was dogs in the neighborhood, and she was just terrified. And little step by little step by little step, she actually went into the pet store, and there was one of these sort of like a sandbox thing without sand with rabbits running around in it. She could go in there and be stand there looking at them, and she even touched one without fainting. It was very arduous, but that's same thing in a organization. Very little steps, takes time. It's not happening overnight, and don't give up because Rome wasn't built in one day. So needs assessment. What kind of trouble's going on? What kind of problems are we facing? Financial, personnel, burnout. People are dreading coming to work because we're not trauma informed. Policy and practice inventory. So that's just like a review of your systems. Formulate goals with measurable outcomes. And this in the mental health field can become absurd. So somebody's an inpatient. What are the treatment goals? Patient will practice positive self-statements 4 times per day. So it can become kind of ridiculous and Mickey Mouse-ish, but the idea and the principle is good. And then how are you going to measure these things? Simple patient satisfaction survey with like 5 questions. Employee satisfaction survey. Get together and talk about it. So again, every time, I can't say walk the walk enough times. And oftentimes in organizations, management talks the talk and nothing happens. So actually supporting staff development, which means, are you getting any paid time to get training in trauma-informed care? You're just supposed to do it on your own. After you get home from work, feed your kids, do the homework, go to bed, exhausted, fall asleep, wake up the next day, and then you got the weekend off, and there's 3 practices and 6 outings, and your husband wants some attention. And so it's got to be like realistic, and there's got to be time to do it. And it's got to be inside the payroll hours of the day and the week. And so just like any development of any system, if you're bringing a new electronic health records on, you'd follow these same steps. And then this is part could get a little kind of touchy-feely and not realistic, but involving the consumers, like what do the consumers think about this? They're the experts by lived experience. Simple consumer surveys, or just asking people on the way out, how was that for you? Anything we could improve? See you next time. So simple. And as I mentioned before, when you're walking into the office from the parking lot, what's the first thing you see? The outside of the building, then the inside of the building, the receptionist area. There's the receptionist. Is she like, hi, I'll be with you in a minute. I have a seat. She doesn't look up. Or is it just like halfway reasonably welcoming? I don't know. Sadly, I've made the comment over the years, not so much of the hospital we're at now, but the previous hospital was in pretty serious disrepair and really grumpy nursing staff. And I often would say, if you came to a dry cleaning place and the dry cleaning establishment was this grungy, you just turn around and walk out. You would not leave your clothes here to be dry cleaned. And if you came up to the person who's accepting the dry cleaning and they had the attitude that the nursing staff has, you'd turn around and walk out. The customer service sucked. Well, so in the mental health field, the consumers are very beaten down, down and out, disenfranchised, have no power in the system. And they just go to the local psych hospital because where else are you going to go? They're all the same. And they don't know what good care actually looks like. So they don't demand it. They don't expect it. It's a sad, sad story. So presenting a trauma-informed care, not fake face, but face, includes your website, your brochure, the building itself, all the administrative staff, the supervisors, the board, everybody, even the maintenance staff, any and all team members. Then who's ever worked in a system where there's too many rules and too many manuals and too many procedures and too much paperwork? Possibly a few people. So adding trauma-informed care, is it really necessary? Do we need it? Why do we need it? Okay, how are we going to implement it? Is it helpful? Has it been helpful? How do we know? Or is it harmful, hurtful? Is it just waste people's time and energy? Back to where consumers included in its development. And could this policy or rule re-traumatize the consumer? It's just basic things to consider. So then there's a lot of education involved. Clients, staff, family members, everybody taught about trauma and its impact. So the mental health system just doesn't do that a huge percentage of the time. And then in physical illness, it's the same thing. Staff, clients, family members all taught about what is the nature of this illness? What do we think are the causes? What's the range of different prognoses? What are the treatment options? How does it affect people's lives? Just standard stuff, but taking time to actually do it. So then now we're getting into the broader world, engaging community, clients, staff in the concept, the practice of TIC. So this is getting into the pie in the sky zone a little bit because, okay, so you've got a primary care practice. What are you going to do? Walk around and knock on people's doors? They're going to send pamphlets. It's really hard to put into action. You could do some community service, which would be under the heading of marketing at the same time. Maybe give some talks. So you just have to try and brainstorm up ways you can connect with them, which these days means you don't have to go outside your house. It's all virtual, online, social media, et cetera, et cetera, et cetera. And is there any evidence-based or emerging best practices to support what you're doing? So it's always good to have a little bit of grasp of the literature. What is the evidence base? Which doesn't mean hundreds of hours in the medical school library, just a reasonable knowledge of the literature, which when it's like, I can't even grasp what it's like to be a family physician. The amount of stuff you have to know about the number of different diseases and problems and all the new medications and the new research and the new this and the new that, completely overwhelming and mind-boggling to me. And then you got to keep up with what's the best evidence-based trauma-informed care. Sheesh, who's got time for that? But if you don't make time, it doesn't happen. And then again, in principle, within an organization like a hospital or a hospital corporation, hiring and promotion could be based on, oh, well, we're going to give a little extra boost to somebody who's really shown interest in trauma-informed care, really advocated for it, really put it into practice. So like anything else, if you reward the behavior, you get more of it. And what about your hiring practices? Do you ask, what do you know about trauma-informed care? What does trauma-informed care mean to you? How would you recommend we implement it here? Would you like to be part of a trauma-informed implementation team in our organization? No? That's all stupid? Okay, thanks for the interview. And then safety, which is a little tricky these days in a lot of sectors of the world. Ensure the safety of the staff, build a diverse workplace. So we hear so much about diversity these days, but it's all important, good stuff. And if the workplace has zero diversity, it's not going to be a safe environment for people from other population groups. And as always, despite the internet and despite Zoom psychotherapy, healing happens in relationships. So just being reasonably safe, authentic, positive, that by itself, you don't have to do anything. Just your attitude, your energy, your demeanor, that's the foundation of a healing relationship. Whether it's just saying hi to the secretary, recognize the importance of physical boundaries and aware that touch, so that's a big thing. So some people are way triggered by touch and they have these reactions or they jerk back or they're uncomfortable or it could be a trauma trigger. So just kind of be aware of that, be sensitive to that. Remark on it. Is something troubling you about this, or you look like you're not comfortable with touch, or is this difficult for you? Is there anything I can do to help you? Just that simple stuff. When I was in medical school, so we would be on call, depending, it'd be either every third or fourth night. And then sometimes we were on call on Sunday. So there'd be two medical students on the surgery service at any time who had to do the histories and physicals because everybody else was too busy and didn't want to do it. And there'd be like 15 to 20 people admitted on Sunday for eye surgery or have prostate surgery. And so it's the same history over and over and over. Trouble with urination, when did it start, frequency, stream, blah, blah, times that you get up per night. And we would take all that history and then we would get consent for the surgery. Because I'm a third year medical student, why am I getting the consent for treatment? And what was the procedure for getting consent for treatment? Oh, by the way, this is the consent form that you have to sign for surgery tomorrow. Your doctor will talk about it more. Could you sign here? And it's like 100 lines of little tiny print like this. And oh, by the way, your leg might fall off or you might have a stroke. But we didn't, nothing, no conversation about risks or anything or options or how the person feels, what they need, no psychotherapy happening. So consent can be done in this perfunctory, oh yeah, we checked that box fashion, or it can actually be like for real conversation, education, consent. I'm just keeping an eye on the time here. So I see we only have one question and answer, so I'll get that in a second. A lot of times, this is a big thing in colleges, everywhere, medical schools. The system just puts the lid on the abuse complaint, and the abuser gets marginalized, and the accused person, who you can't be guilty until proven innocent, so it can be overdone in the opposite direction. But historically and up to the present, institutionally, keeping a lid on any kind of sexual harassment complaints, professional misconduct complaints, rape on the college campus, it's just a culture of silence and suppression a lot of the times. And having a clear organizational plan for dealing with behavioral crises instead of just fly by the seat of the pants. And then the documentation, just keeping an eye on what's the language they're using. Don't have all this words. This is the borderline case description: attention seeking, needy, unprovoked responses, nothing helps, difficult patient, treatment resistant. That's one of the terms I like the least, treatment resistant. What it means is somebody with severe problems and we have no idea how to help them. But no, it's not us. They're treatment resistant. Just again, creating a sense of safety. letting the person know, like, how does it work around here? What's going to happen? Who are the people? What are the steps? And embedding it into meetings, calendars, organizational chart. And you don't just kind of start doing it, you actually talk about it and out loud make a verbal commitment to this and follow through on it. And then feedback within the organization, feedback from the individual clients, feedback from the community. And trauma informed care is not based on weakness or damage. It's not based on what is wrong with you. It's based on what happened to you. How is this an understandable part of your attempt to deal with trauma as opposed to just symptoms of a disorder? Instead of attention seeking, you don't have the healthiest coping strategies. You didn't learn them as a kid. You're trying to connect in the best way you know how. It needs a little tweaking. Instead of manipulative, well, you never got your needs met. And if you asked to get your needs met as a kid, you just got slammed down. So you have trouble asking to get your needs met. So you have to resort to manipulation. And I'll say, well, you went to the school of manipulation because your family was so manipulative. Challenges and rewards. Well, the challenges are the whole organization just like can't cope with it, doesn't have the time, doesn't know what to do. If you even acknowledge trauma, somebody will become flooded. I won't know what to say. I don't have the time. I don't have the skill set. I might get triggered myself. All these concerns are part of the discussion, part of the training. So it's like grounding and desensitizing the staff. And when trauma is disclosed, whether it's big or little t, just listening, provide basic education, have good boundaries, and don't vicariously traumatize yourself or the other person. And vicarious trauma is like just getting fried from listening to all these trauma stories. So part of trauma informed care is having a care plan for the people who are dealing with the trauma. And all of this is like close to possible to do in organizations where there's staff turnover all the time. There's no leadership from the top down. There's not enough funding. There's all kinds of resistance. And so you just get trauma-informed care fatigue from even trying to do it. Really keeping an eye on time. So trauma-informed care doesn't have to be more expensive. It doesn't have to take a ton of time. And there's literature showing it improves the physical health of clients and providers, improves retention and treatment. In one study, it really dramatically reduced staff turnover, which equals training costs, equals burnout, decreased sick time, and workers' compensation claims dramatically reduced. So this is a series of references here. And real quickly, I guess I can answer the question of thank you very much. You're most welcome, Rosie. And otherwise, nobody put anything into the Q&A. So I guess you were all in a serious catatonic state because I re-traumatized you too much. Apologize for that. But thanks for listening. So the basic message is trauma-informed care really should just be standard care. It doesn't have to be ultra fancy, take tons of time, but we're a long ways off the mark in a lot of the healthcare system. So again, thanks very much. And looks like it's 10:30 now. Time to stop.
Thank you, Dr. Ross, for that wealth of information. We received quite a few positive feedback in the chat box. I want to say, I don't see any other questions in the Q&A, so we'll probably, draw this to a close. Thank you all for your patience in attending this afternoon's event. Thank you to all of our speakers, especially for sharing their time and expertise and how we can become better trauma-informed care, offer that in our community, and for partnering with AHEC and Amarillo College on this event.